Okay, so thank you very much for having me today. I'm sorry I cannot join you in person, but I hope you are all keeping safe and enjoying some good weather in Paris. My name is Dr. Sally PEZARO. I work at the University of Coventry in the UK. I'm also an adjunct associate professor of the University of Notre Dame in Australia. And I've been editorial member of several midwifery journals. I'm a fellow of the Royal College of Midwives and an invited member of the International Consortium on the Ehlers-Danlos syndromes and related disorders, and also do some work for the Nursing and Midwifery Council. So I have an investment in making sure that midwifery can be the best it can be and provide the best care we can to people having babies. And I will explain to you a bit more about my journey and how I got here shortly. But today I'm here to talk about my journey as a whole, looking into hypermobile Ehlers-Danlos syndromes and hypermobility spectrum disorders in the context of childbearing. And I've been doing this with a number of people over a number of years now, academically, through research collaboration and largely co-creation, which has been a real journey for us. And we're coming to some exciting results and outputs with that. So something I want to draw your attention to is headstogether.com, which is a website and collaborative of resources where resources are pooled, made freely available where possible, and outputs are there for free download, for further reading and for use with clients and for educational purposes, and for yourselves. And anything downloaded from there for free, we'd love to hear from you if it has been making a difference in practice or making a difference in the way we care for people having babies with heads or hypermobile spectrum disorders. So on the left there, our core team and lead Heads Together lead is Dr. Gemma Pierce, who has heads herself. Then there's myself, I'm the lead midwife, and we do a lot of work around pregnancy. And we also have Paul McGee, who's our senior designer, who helps us design some of the tools we use to support people giving care to these populations and the populations with heads themselves. But if you go to headstogether.com, you'll find there's actually a lot more people we collaborate with and all of their biographies there for you to look into. And I know they're a very collaborative bunch, so we'd be looking to link up and see if there's more work we can do in this area. So the first thing we did when we were talking was thinking about, okay, people with hypermobile Ehlers-Danlos syndrome get pregnant. How does that happen? What happens during pregnancy? How is it managed? How does it affect pregnancy? And when Gemma came to me and asked me that question, I really didn't know. I'd never come across the condition, although I'd been a midwife for several years, providing clinical practice. I just didn't know how this condition would affect pregnant people, although I could very well guess how it would because of all the connective tissues affecting them throughout the body. And then pregnancy comes on top with added weight, added hormones, added symptoms of pregnancy on top of that. So we really needed to have a first go at looking at the literature, seeing what was out there, what was already done. So we published in 2018 in the British Journal of Midwifery hypermobile Ehlers-Danlos syndrome during pregnancy, birth, and beyond, which is basically a summary overview of what the condition was and how it might affect pregnancy based on what we knew clinically and what we could derive from the literature at that time. Quite an exploratory piece, an early piece to get the word out there. And that article, when it was published, was, I think, the most highly downloaded paper from that journal. I believe it still is the most highly downloaded paper from the British Journal of Midwifery. And for that reason, they made the paper open access for everybody to read, which was really great because people could download it, share it with their clinicians and with other people with heads, and really get the word out there about what this might mean and raise awareness, really. And then in 2021, we decided we needed to move on and do a clinical update. Things move on, more things are being published. So our 2021 clinical update paper came out with kind of recommendations. It was more considerations, thinking about, if we know this, then perhaps we need to do this, or if we know this, maybe we should think about doing this. And that was really useful for people again, because there was more papers published and more things we could talk about. Our own knowledge had grown since we'd been talking to experts, being involved with the Ehlers-Danlos Society, and we could move on and tell people more things about that. So some of the early things we discovered was that, there's massive adaptations in connective tissues when people grow and birth a baby. And because connective tissues in these conditions are already affected, that there's a big knock-on effect for a lot of people in terms of exacerbation of pregnancy, or it could be a catalyst for change, something being diagnosed because it's so profound, or there could be not much change at all. We found that it's no longer considered to be rare, although people will say, oh, that's a rare condition, why do we need to look at that? It rarely ever happens, it rarely ever affects pregnancy. We're finding more and more that Ehlers-Danlos syndrome, especially hypermobility type, is not rare, it's just rarely diagnosed. And so there's lots of work to do around raising awareness of that. And it takes an average of 16 years for cis women to be diagnosed with EDS from the time of development of significant symptoms. So again, we're thinking about the childbearing years of somebody, and then that 16 years of time to from beginning of symptoms to actually getting a diagnosis. A lot of people will be giving birth to their babies without a diagnosis. And so it's even more important that if there are profound catalysts of change, big connective tissue issues, then we should be thinking about perhaps a diagnosis is required, or at least a referral, given the profoundness of symptoms. And concerns could be exacerbated over the lifespan. And when you're pregnant, those concerns could be exacerbated, so highlighting a problem if you didn't know it was there before. Also, we looked at the symptoms of pregnancy. The things that were coming up in the literature was cardiovascular autonomic dysfunction, orthostatic intolerance, reflux, and bowel dysmotility. Lots of links with migraines coming up and urogynecological problems. Mast cell deregulation was coming up quite frequently, and increased rates of pain, obviously, because again, systemic connective tissues, but also joints. And if people were already having joint pain, then the pregnancy would put weight on those issues and exacerbate the problem. And sleep disturbance and general reduction in health. And because of all those things combined, really, that resulted in, we think, increased diagnosis of psychiatric disorders, including autism spectrum disorder and suicidal ideation, and in decreased quality of life as well, because they're having to deal with these problems on top of a pregnancy, which is also challenging. So generally, we found in the literature at that time that pregnancy was generally well tolerated, while problematic and challenging at the same time. Some articles were reporting lower fertility rates, but in our more recent study, we did not find that came up at all. So there's still more research to be done there. And the symptoms of pregnancy can be exacerbated and vice versa by heads. They can experience disabling increases in joint laxity, along with a variety of urogynecological problems, again, because the condition is exacerbated by the pregnancy. And not surprisingly, pelvic pain and joint instability are common, and hyperemesis gravidarum and carpal tunnel syndrome are challenging. So excess sickness, presumably again because of the smooth muscle being even more affected in terms of their connective tissue with HEDS or HSD. And then pelvic girdle pain as well, because of the hormones rushing in early pregnancy and impacting upon already compromised connective tissues in some cases. There was one study reported of bladder diverticulitis developing without any obstruction of the urinary bladder, but we think that may be because the growing fetus was pressing over the bladder, so could have been compromising that there. There's a need for early referrals to physiotherapy and general practitioners where possible. Even if problems haven't occurred early on, it's likely that extra support put in place will minimize any exacerbation of those problems. And due to the increased hormones of relaxin, varicose veins and reflux can occur, purely because of the increased relaxin in the muscles and the connective tissues. And for that same reason, we also see problematic varicose veins, which we can manage using compression hosiery or referral to vascular service, and these could be in the legs or in the vulval area in particular. Increased gastroesophageal reflux or sickness during pregnancy can be managed via standard treatments. There's no special treatment here that's been unearthed in the literature. And joint hypermobility and instability are generally best managed conservatively with the use of physical therapies, orthotics, and avoidance of movements that are going to exacerbate the problem, which again is why physiotherapy early on is really useful in terms of getting that those things in place to manage how we can minimize those problems exacerbating. And diverticulitis and herniation can occur and be managed conservatively unless chronic, in which case surgery may be required, but that's on an individual basis. We also had to look at POTS for obvious reasons. About 78% of those with HEDS or HSD potentially affected by POTS, and in pregnancy this can also compound on the things that are already happening. So in one study, a pregnant woman diagnosed with autonomic dysfunction, where autonomic dysfunction was present in 55% before pregnancy, this rose to 100% during pregnancy. And symptoms such as trouble concentrating, lightheadedness, palpitations, fatigue, exercise intolerance, and in severe cases, fainting also occurred. And throughout pregnancy, birth, and beyond, the symptoms of POTS can be variable, but actually up to 60% of people with POTS report improvement during pregnancy, because we know that during pregnancy, the blood volume increases by about 40%. And that can actually support people who are having symptoms of POTS. So we've got decompensation there, and immobility in the third trimester of pregnancy, occasionally needing hospital admissions there because it's worsening right at the end. Overlapping symptoms of HEDS, POTS, and mast cell activation system and their underdiagnosis means that the potential link should not be ignored. There was a paper published a couple of years ago on that, but really they still seem to occur commonly in practice together. So there's definitely more research needed to be done there. And unfortunately, there's no uniform guidance in caring for those childbearing with POTS, although there has been something published slightly more recently, and we'll be incorporating them in our guidelines as well. But really, it's important to seek early review with an obstetrician and an anaesthetist to engage in timely evidence-based discussions. There can be some tailored exercises done aimed at improving ability to remain upright, along with the use of compression hosiery. And as a first-line therapy, oral hydration and salt was considered. But obviously, you've got to balance that with the hypertensive disorders of pregnancy, if that's to be achieved. And also beta blockers can be useful. Continuing any medication prescribed preconceptually can reduce symptoms, and no risks has been identified in such cases. And then if we think about when actually giving birth, the build up to active labour may be slow for those childbearing with HEDS, but active labours and births can progress very quickly. This is something I've certainly noticed in clinical practice, where someone will be labouring perhaps in the latent phases of labour for a very long time with an irritable uterus, nothing really happening, and then all of a sudden there's a baby there. And I now look back on those cases and wonder whether they were in fact people with undiagnosed HEDS at the time, where their uterus was behaving like this because of the connective tissues being perhaps extra lax, and then allowing a baby to shoot through and be born very, very quickly. So they might be somewhat attributed to increased joint laxity, also less frequently requiring the use of instruments to aid in the birth, because stretchier skin and stretchier uterus opening up very quickly. But for that, they can be unexpected for healthcare professionals, so quite a shock. So they can be quite underprepared for birth, because they think that they've still got hours to go, but they haven't. It's coming very, very fast, and so it may be prudent to plan for a home birth, either as a contingency where appropriate, because people might not actually be sent home and then not actually get back to the place they intended to birth their babies, because that birth happens super, super fast before they can get there. So there's an increased risk of premature birth, that's well documented within several studies, and also abnormal fetal presentation because the baby has more room inside to move about because of the laxity of the uterus, enabling that movement more frequently. But those childbearing with heads should not be discouraged from birthing their babies vaginally. We didn't see any need for them to be born via cesarean section more frequently than anyone else. There was one American cohort, a large cohort of all EDS subtypes, so not just hypermobile type. And 910 of those were found to be more likely to need cesarean section compared to those without EDS. However, the context of America is quite different in that they do have a highly medicalized system with more instrumental births and cesarean births in general with a risk culture. So I would look at those results with caution. And then those with joint height mobility, defined by a Bateman score of more than 4, are less likely to birth via cesarean section or vaginally with the aid of instruments after completed cervical dilatation, and compared to those without. And that was the same study. So it's interesting to see how those outcomes come about. But also, I do think it's important to look at the different subtypes of EDS separately. And what tends to happen in these studies is they pull them all together as EDS and don't look at the individual subtypes as they perhaps should. So consider hemostasis and a gentle handling of tissues. Optimal maternal positioning and joint support's really important during birthing, labour and birth. If episiotomy is indicated, some may advocate for birth via cesarean section because that may avoid the risk of increased tearing and pelvic organ prolapse. So consider that at the time. It's not an either or, but people tend to have lots of issues with episiotomies and prolapse in these populations. And then with POTS, again, decision making in relation to labour and birth should only be based on obstetrical considerations rather than simply a diagnosis of POTS. And in all cases, it's really important to have an environment which is conducive with calm and relaxation to reduce pain, and to let the body do what it can do physiologically, to the benefit of the situation and outcome. In terms of anesthesia, local anesthetic can be ineffective, and we found that in all of our studies in terms of lidocaine being used for repair, perineal repair, or episiotomy. It's very ineffective even with full dosage, and it's been associated, EDS has been associated with cerebrospinal fluid leak and should be suspected in those with heads, especially if they experience ongoing orthostatic symptoms following epidural, for example. Oh, the television's gone off in the room. I'll wait to see if you can still hear me. I've been cancelled. Oh, we're back online. Wait for you to log back on. I'm not sure if you can still hear me. Can you still hear me? I can see a nod. Okay, I'll carry on then. So we were talking about anesthetic considerations during labour and birth, and increased rates of cervical spine instability and anesthetic resistance and hypertension after an anesthesia should be anticipated, unfortunately, and may be difficult to site epidurals because of the different spaces between the spine not being atypical as you might expect. And then in terms of POTS, epidural, bolus and/or infusion with phenylephrine during childbirth can be useful in preventing reactive tachycardia in the presence of hypertension with peripheral vasodilatation. So that can actually help someone by reducing pain and therefore reducing symptoms. And strategies that promote spontaneous pushing in favor of directed pushing are recommended, but really they're recommended in all birth. We shouldn't be directed pushing. We should be enabling and empowering people to birth the baby in which they physiologically are inclined to do. Monitoring of hemodynamic parameters may be advisable during the second stage of labour, because when people start pushing, experience pain and have fluid loss, they may have a worsening of symptoms. So that early pain relief to reduce that tachycardia and associated complications is highly recommended in people with POTS. And birthing environments that promote calm and relaxation will also be highly valuable, because obviously you're then promoting calm, which reduces pain, which avoids the risk of more symptoms becoming a problem. So that's always worth thinking about there. And in terms of postnatal considerations, what we found in scoping the literature is that some can struggle to recover from birth, both physically and psychologically. Any tissues that have been damaged during birth can be problematic to heal. Abnormal scar formations can occur with hemorrhage, pelvic prolapses, and these may be associated with episiotomy, deep venous thrombosis, and complications in perineal wounds. Also, coccyx dislocations and separation of the symphysis pubis has been reported in both our research and other people's research. And there's an increased risk of urogenital and pelvic complications, such as recurrent urinary tract infections or incontinence, and gynecological symptoms such as pain or prolapse. And then those left with chronic pelvic girdle pain are at significantly increased risk of suffering from anxiety and depression because of the impact on quality of life on a day-to-day basis, and obviously that constant pain and limited movement. Use of non-tension, non-dissolvable, deep double sutures left in for at least 14 days is advisable because of the disadhesance of wounds. They don't stay closed, they take longer to heal. And if you get disadhesance and wounds coming apart, obviously that will inhibit the wound healing. So non-dissolvable deep sutures left in for longer can assist with that. And then PGP, so this is the pelvic girdle pain. Last line treatments may include intrapelvic corticosteroid injection and joint fusion, but that's last line treatments because we understand things can get really bad, so bad for people, it becomes worth considering those options. Multidisciplinary working with clinical psychology, psychiatry, pain management, physiotherapy, rheumatology teams in line with summarized recommendations can be useful in the management of PGP for obvious reasons. And frequent joint dislocations, along with difficulties in holding and caring for and bonding with the baby or breastfeeding, can also further complicate parenthood because they can't stay in the same place to breastfeed their baby for too long because they can't support the joints for that long. So then parenting becomes an issue, and then you get the biopsychosocial implications on top of that. But some may be improved through strengthening exercise and physio again, or support pillows and cushions and wedges to help with parenting in the early days. For those with POTS, further encourage breastfeeding where appropriate in order to stimulate the secretion of oxytocin, and that has therapeutic anti-diuretic effects for people with POTS. So it may actually improve symptoms if people with POTS decide to breastfeed. And for migraine, lactation can also have protective effects against migraines. So if breastfeeding is an option, it's a good one to take. And then for the baby, a baby born to a parent with HEDS has a 50% chance of inheriting it themselves because it's autosomal dominant a pattern of inheritance. It has been suggested that these newborns be thoroughly examined for symptoms of these conditions at birth, but most people don't recommend diagnosis at birth because we're allowing babies to grow and thrive in their own way. Newborn hips may be clicky, have joint hyperlaxity and dislocatability, and newborn skin may feel doughy and split or bruise easily. So consider joint support when doing any kind of procedures with these babies. Consider high incidence of floppy infant syndrome, prematurity, and preparations may be required to receive and support the preterm infants transition into the world. So prepare for resuscitation just to be on the safe side and support the baby at all times. There's a real importance here of clinically documenting everything with this newborn baby. Because some researchers found bruising comes about, and then there can be false accusations made about where those bruises came from. Also, there can be dislocations and fractures in utero that may be missed and then misconstrued as something that is perhaps a foul play. So if we document everything at the times, what we see and what we're observing with the babies, that can be really helpful and avoid a lot of pain later on. So once we'd done these initial examinations of the literature and published these considerations we thought might be useful, we did our own study using primary data where we interviewed people with hypermobility, hypermobile understanding loss syndrome and hypermobility spectrum disorders and had babies. So that was an international study. And the findings from that were published in 2020 were then used to create case studies or case scenarios. They weren't verbatim because we needed to maintain anonymity. But the case study of Sandy's story and Cindy's story were put into an iLearn module, so an online learning module for midwives by the Royal College of Midwives to help them understand what this condition was and using the power of stories to help them understand how to make their experiences better in future. Now, this study as a whole, we did 40 narrative interviews. These were online interviews via Teams because some people found it much easier to type with heads than talk or move or travel somewhere. Our participants were aged between 25 and 55, and we captured 52 births between 1981 and 2018 across the United Kingdom, the United States of America, and Canada. It's estimated that HEDS affects approximately 1 in 20 pregnancies globally, and we managed to provide that estimate within this paper. And some childbearing with the conditions will experience an entirely low-risk pregnancy and birth, while others may experience significant issues or anything in between. And that's really what we found with these 40 participants as we had long conversations about their stories and their experiences. We also saw they had a real perceived lack of preparedness and clinical knowledge and awareness amongst healthcare professionals. When they were going for their appointments, they were saying, they've never heard of the condition, they don't know what to do with me, I'm not getting the care I need. And they recounted a worsening of symptoms during their pregnancy and postnatal complications. Anesthesia again was often reportedly ineffective, so it didn't work for them. And for many, long latent phases of labour quickly developed into rapidly progressing active labours and births. And maternity staff were observed to be panicked by these unexpected outcomes. They weren't expecting them, they weren't ready for them. And in some cases, poor maternity care resulted in women disengaging from services, trauma, stress, anxiety, and an avoidance of future childbearing, which is really highlighting for us the need to improve education and awareness in this area for perinatal staff working with these people. 1 in 20 pregnancies is not a low number. And so we'd really like to work to expand education in this area. So you can read that open access article online, but next I'm going to share with you some voices from some of the participants. And I hope you can read that, and I'm very happy to share slides after the presentation. But you can see that some people were taken off work by the time they were in the fourth month of pregnancy because the hip pain was unbearable. They had to crawl to the bathroom at night because it was gone so bad. They said, one said they had bleeding about 6 weeks, which scared them about miscarriage. They had some early scans, but in the end they said, I had fragile membranes because of EDS, but there's no real explanation for that antepartum bleed. And then the next one is my favorite comment, which is, I remember him, the junior rheumatologist, saying, "You're not hypermobile. You can't touch the floor." And I'm thinking, I'm 8 months pregnant. Of course, I can't touch the floor. So that kind of real mismatch between the patient experience and the reality of the situation. Also, another story where the consultant would tell the patient that they were making up results because they wanted to hide that they had gestational diabetes and was making up diagnosis of EDS, and told them that it only makes them good at gymnastics, not at childbirth. So really kind of degrading comments there. And another person wanted desperately to have conversations about vaginal versus cesarean birth, but was told there was nothing that could be decided until 6 weeks before. And at that point, when I was merely asked if I decided which one I wanted, so no real conversations happening around what could potentially happen in EDS around the time of birth, and making that informed choice as to where people were going to have their birth their babies and how. But then, there were people that say it was refreshing when I saw an anaesthetist and he was aware of EDS, listened, and it was like a weight had been lifted. He told me that so many of us with EDS are used to being not believed. So there were some good clinicians out there. And here's an example of where someone had a very, very fast birth, where they said at 7 a.m. I was examined and I was 1 centimeter. At 7:30 a.m. I asked my husband to get the midwife as it was happening. She examined me again and I was 4 centimeters. We went to the delivery suite, and after a little bouncing on the ball and some gas and air, within 3 big pushes, I gave birth at 9:30 a.m. And another one where they said I was advised I had now reached 10 centimeters fully dilated, which was just 1.5 hours after my 1 to 2 centimeter examination. So very, very fast progression, which can obviously result in increased risk of hemorrhage and also shock to the baby being born so quickly. And here, with regards to not having anesthetic working, someone said, "I can still vividly remember the feeling of the thread being pulled through my skin and feel I am still a bit traumatized by this." And here's just some more that I wanted to share with you. My husband and I walked away feeling trauma from our experience, given that we were prepared for work that day, went to a medical appointment figuring it was routine, and shortly after I was told I might lose both babies and I was going into spontaneous labor. I was shocked. It was shocking and unexpected. My husband looked at me in full horror because the baby was rushed out of the room not breathing and I was hemorrhaging. If I'd been diagnosed before pregnancy, there are things I would not have even contemplated: water birth, birthing center for first birth. I would have also researched pain relief, etc. So this is again about, being diagnosed before you have your baby, or during pregnancy or after pregnancy. People definitely feel they would have made different decisions had they known differently. And then another person said, "I had from my son an episiotomy and I now still have problems with prolapse." But yeah, you don't know really how to compare it to other people. But certainly pain afterwards was still there with the healing, and it seemed to take quite a long time to heal. I think the prolapse is maybe part of the elasticity and the whole problems and the bowel side as well. I still have problems there. So this postnatal recovery goes on for a long time, and in some cases hasn't ever got better. If I buzzed for help, I couldn't sit up to feed my baby. I was made to feel like a failure. I didn't breastfeed because I was told if I did, my hormones would carry on and my hips would still be as bad, but I was made to feel bad for the decision. And again, I was told I was lazy for not changing my baby son. The truth was, I was in agony and struggled to get the help I desperately needed. I felt I had to push through it, and it had a detrimental effect, both mentally and physically. And on my third day of a review, my midwife came into my house. She started questioning me about how my baby got her bruises. She had read C-section, but didn't read the rest of the notes. When I explained to her, she said they never use forceps in a C-section, went back and read the notes, and then apologized. So again, that's really illustrating how it's really important to do your documentation early. And then someone else says, "I have lots of pain and subluxation in my wrists. I suffer from back pain from lifting, for holding her. Every day is a constant struggle to cope." I was in agony. I could feel the burning and ripping sensation. They tried chopping up my epidural, but nothing worked. And that was again another failure for anesthetic to work. So I just wanted to share those participant quotes because I think they're quite powerful in illustrating our findings and informing us on what's needed next. So in terms of what we did next, we looked at forward to solutions and what we could do to make things better. So we did 2 online mixed methods international surveys, and we asked childbearing people and perinatal staff to complete those, so we could find out more about what was going on. This was then followed by the co-creation of 3 tools with 17 co-creators and a design team, and I'll share those with you today, what we co-created. And basically, the professionals said there was a need for recognition of heads in perinatal care through building professional knowledge. They recognized they needed that knowledge and their colleagues needed increased knowledge to make things better. They wanted evidence-based guidelines and accessible training resources, and they wanted improved diagnosis for people with heads to help them do their jobs. But there was a reported low levels of confidence in supporting people with heads. And then women with heads perceived professionals supporting their perinatal period to have low level of knowledge about heads with no significant difference in care, regardless of diagnosis before, during, or after conception. They basically said they need appropriate individualized care. So what we did was co-created, like I say, 3 tools with 17 co-creators, and we've recently published last month how we created those solutions and presented them free for use. And this work won an award. So this work won an award for partnership working with the Royal College of Midwives. So it's really exciting to have this work out here for everybody to download and use. We were hoping to get it translated and used in other countries. So that would be really awesome if people are looking to do that. The first tool co-created by Heads Together is this decision-making tool. And really, this is designed to be freely downloadable. You can look at the QR code on the screen there, or again, headstogether.com. Freely download it, upload it to other systems, or print it out and put it in patient records. It's a decision-making tool to have conversations with clinicians and people who are having babies with heads, to think about things to consider and discuss and what might happen because of HEDS and pregnancy. Then write down things that are unique to them, things that they can do to support them, and things that might make symptoms worse. So people know their bodies better than anybody else. They know which part of their body is exacerbated by certain types of movement or certain procedures. So it's about having that individualized approach. And then in the bubbles at the top, you can see that there's a few facts and figures about HEDS and pregnancy. If the clinician is really clueless, these are just a few pointers to get them started and thinking about what this might mean for this particular patient. And again, they can go and do further reading on the headstogether.com website to read our other research papers there. So that was the first tool we co-created. Parents and staff making decisions together. That was from our co-creation workshop, where we had a digital board which people could write on. So we included some of that. Then we also co-created an infomercial. So this was filmed during the pandemic, and we were able to film a video informing people about the condition, what it might mean, and why they might use the tool in practice, how they might use that co-created decision-making tool in practice. And that's available on YouTube. And it was hosted on the Coventry University YouTube channel, but of course it can be shared and inputted into other educational toolkits. And then the Royal College of Midwives kindly let us expand on our iLearn module, which is an online learning module for members of the Royal College of Midwives to access and learn about what HEDS is, what the prevalence of it is, learn about people's experiences, the role of the midwife, learn about those stories, care of the newborn, and what they might do in practice. So that was really, excuse me, that was really supportive of the Royal College of Midwives to help us to do that, because it means that that's there and freely available for their members to learn online. And we were able to put our research into that to make it a research-enriched learning experience. Then we did another large international survey of outcomes and complications with people childbearing with hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. And again, this was published in just last month, so it's newly out. I'm glad to share it with you today. It was a large online international survey completed by women with experience of childbearing and a diagnosis. So we had 947 people take part and a total of 1,338 pregnancies included in that data. We had pregnancies in the UK, USA, Australia, Canada, New Zealand, and Ireland. And while you could read yourself that paper, it's freely accessible. Incidences were higher in people with EDS than typically found in the general population for the following, and that's preeclampsia, eclampsia, preterm rupture of membranes, preterm birth, antepartum hemorrhage, postpartum hemorrhage, hyperemesis gravidarum, shoulder dystocia, cesarean wound infection, postpartum psychosis, post-traumatic stress disorder, precipitate or very fast labours, and being born before arrival at the place they intended to give birth. So they're the highlights, really, in terms of the things we think may affect people with heads in a greater way than the general population giving birth. And also we have to think about now, are the symptoms we typically think of in pregnancy that we think, oh, they're just regular symptoms, regular things that happen, are they actually related to people with heads, considering we now think that 1 in 20 pregnancies is affected by heads? So that's a really important and large international survey we now have to inform future guidelines on. And that's what the professionals said they wanted most. They wanted clinical guidelines to support them in their decision making. And now with all this evidence behind us, I've been working with the International Consortium of the Ehlers-Danlos Society to co-create the international guidelines on the management of heads and HSD in childbearing, and we've been working on those for a couple of years now. We had consensus meetings in Rome and Arizona last year, and we're just finishing up the last literature reviews and writing up of those guidelines, and we're hoping to publish them in the new year. And it's been really exciting as a midwife to be leading guidelines in this area, both professionally and personally. But also, I think it's a culmination of a lot of work by a lot of people really passionate about this topic and really understanding the need to move things forward for people childbearing with heads and HSD. And I think professionals recognize it too. They just want more tools and education in order to do their best every day for these people. And it's hard at the minute where we don't have the research and we don't have the evidence, or as much as we'd like. But I hope to share with you the guidelines when they come out, and I'll share these slides with you today so that you can go through the other research and follow us on this journey. My last slide is a thank you and a question slide. If anyone does have questions, I know I'd be keen, and the Heads Together team would be very keen to get together with people to work on more issues with heads and pregnancy, because we're kind of becoming experts in this now and looking to do more. So if there are any questions, I know there's been some in the chat come up, then I'm happy to answer them. My email and my online tag are also on screen if you wish to connect. But thank you very much for listening. Okay, so I'm just going through the chat now. Sorry, I didn't realize you could still hear me when your computer went off. I hope I didn't swear. So some of this is written in French, and I don't understand a lot of it. But a couple of the questions at the end. Do you already have criteria for epidural anesthesia or guidelines? We've included anesthetics in the guidelines we're working on. So when we publish them guidelines for the management of heads and childbearing, one of the sections of the guidelines will relate to anaesthesia. But they are not comprehensive, and we don't have enough evidence to say exactly what to do or not to do, because it just hasn't been done. But we did have an anaesthetist consult with us, and so we could at least give some recommendations with regards to bolus doses of local anaesthesia where required, and on spinal anaesthesia, not perhaps working as well as it should, and anaesthetists being aware of that. So we've tried to put that in to the guidelines we already have. And in terms of another question, have you studied egg freezing too? We have not. There's no genetic, no gene found yet with anything, although we do have a genetic counsellor on our team who does genetic counselling. I'm not sure that the egg freezing has been included in the guidelines, again, because there's not much research on that came up in our literature searches, and I certainly am not involved in any research that does explore that freezing of eggs. So if anyone else can translate for me some of the other questions aren't asked, I'm quite happy. Your end is on mute, so I will read in the chat, continue to read in the chat. Okay. Did I observe problems with breastfeeding or baby not being able to take the mother's milk? That hasn't come up in any of the research we've looked at. It may be an issue with swallowing and soft tissue, but it's not come up in anything any of our participants have said, and it's not come up in the literature we've reviewed either, anything like that. Any other questions?
Sally, do you hear me?
I can, but there's an echo.
Yeah, sorry about that. We didn't have any translation here, so we're doing our best.
Yeah.
Thank you very much for your intervention. So we'll get in touch with you later. Okay.
Okay. Thank you very much for having me.
Thanks a lot.
Okay. Take care.